It's an absolute honor to be here with such a highly motivated group of people that are doing absolutely everything they can to maximize their quality of life. And I'm sure you heard from many of the surgeons and treating physicians before that this is a major focus for all of us. And so my goal today is really to give you some tools to know how to treat your symptoms, how to communicate those symptoms, and oftentimes you'll know more than the doctors if you know these basic things. So we're going to communicate your symptoms effectively, how to treat your pain effectively, how to anticipate side effects, and then resources for maximizing your quality of life. I actually encourage questions throughout. So if you're asking questions, that means you're listening, and I'll just go with it. So when you are talking about pain, it's important to know what your treating team is actually wanting you to say to them so that they can treat your pain effectively. And so for our medical students, we often will describe the PQRST. These are quality, radiation, severity, duration, the temporal profile. So you do your best to say, I have pain, and I think it's very challenging in this particular cancer type because the pain can be pretty nondescript. So you do the best you can to describe the pain that you have. Constant pain is a little bit of pain all of the time. You have breakthrough pain that just all of a sudden this comes out. And then there's something called intermittent pain or incident pain, which is pain that happens when I do a certain task or activity. And the classic example of that would be someone who has a broken bone, who when they walk it hurts, for example. So the WHO has this, all of us are taught in medical school about the WHO ladder for pain and how we approach pain. And we divide reported pain into a low, moderate, or severe. Low being a reported pain of 1 to 3, moderate 4 to 7, and severe 7 to 10. I don't like the ladder for multiple reasons. And I like to point this out to people. The first reason that I don't like this ladder is that everyone assumes that the safest medications are in the first step of the ladder. That the more scary medications are getting into the second ladder, and then the most scary are in the third. The other reason why I don't like this is that if you come in and you are at a pain of 10 out of 10, let's say I had kidney stones, I don't want you to go up this ladder and give me an aspirin at first if I have 10 out of 10 pain. So I'd like to go up on the elevator, and if I'm at the 10th floor, you're going to be giving me what I need. Okay? So when I say things like morphine, hydromorphone, oxycodone, and fentanyl to patients, they frequently are scared. These are opioids. These are narcotics. I'm afraid I might become an addict. These are all concerns that they're having. They're also concerned about some of the side effects associated with those medications. And I can tell you that if these medications are appropriately dosed and used, that they're extremely effective and safe. In contrast, some of the side effects associated with aspirin and Tylenol or acetaminophen can be very severe, including GI bleeding, liver failure, issues with kidney failure. So just because these things are over the counter doesn't mean they also don't have side effects. And then these combination products, these were created for convenience, but additionally, because they also contain usually Tylenol or a non-steroidal anti-inflammatory, there's a maximum amount that you can take each day. And because of that, you can only take so many of those pills. If you need more than that, which frequently people do, then you really need to rotate to the true opioids because there isn't a max. Okay? So I just want you to know that there's a science to this. This isn't like, oh, I choose, you get morphine, and then you get some oxycodone, and I'm going to start you at 30. And there's actually a whole science to the conversion, and we're taught how to do that. And it's not one-to-one. So I just want you guys to know, just because you get 5 of this drug, it doesn't mean it's 5 of that drug. There's a whole science to it. And we teach conversion methods. So I just want to go over a common misperception, which is the difficulty in understanding long-acting pain medication and short-acting pain medication. And so this is a typical example, and when I talk to patients about their pain, they'll say they have a little bit of pain all the time, and then they have this breakthrough pain that occurs. And it could be while they're doing an activity, or it could be out of the blue. So for that pain that you have all of the time, there's a special formulation of pain medicines that are available to give you a little bit of pain medicine over an 8 to 12 hour period. And then on top of that, you have short-acting pain medicines that are really supposed to be used for those breakthrough doses. So I don't actually think most people are taught this. They're usually just given a prescription and say, good luck. This says 1 to 2 tabs every 4 to 6 hours as needed, which I can tell you as a patient, I don't know what that means. What does that mean? 1 to 2 tabs every 4 to 6 hours? So when your pain is further out of control, you need to be able to describe what's changed, and then we need to also make sure that your pain medications are increased to reflect your need. So this is something that I think a lot of medical students are still having a struggle with. We'll have the same drug, but there will be a short-acting form of it and a long-acting form of it. And this, I think, for caregivers is especially difficult to understand because you have oxycodone, and then you have OxyContin. You have morphine, and then you have Oramorph, or you have KDN, or whatever. And trying to keep the short and long-acting is complicated and confusing, especially when the names are so close. But what I want you to understand is, like for example with morphine, it's the same drug. It's just that the delivery mechanism is different. So for a long-acting form of a medication, you're getting the same exact morphine that you would for the short-acting, but the delivery of how you absorb it is going to be over 8 to 12 hours. So you would never take a long-acting pain medicine for breakthrough pain. Does that make sense? Where you have the short-acting, which we know gets absorbed much quicker. So this is something all learners who come through my clinic have to learn. And I frequently, the butcher paper on the exam table? I'm always writing on this, and I send people home with wads of butcher paper. So we talk about the concentration of the drug over time. And you're going to get the most bang for your buck out of a medication when you reach the top of that hill. That's called the maximum concentration. So I will ask my patients, if you take this pain medicine, when do you think you get the most relief from that pain medicine? And if it's a short-acting pain medicine. And on average, people know the answer. It's about an hour. Half-life, this is pharmacokinetics. I'm teaching pharmacokinetics to you. It's great. Half-life is when half of that drug gets out of your body. Okay? So knowing that is really important when you're taking your pain medication because oral, you're going to get the most effect of that medication at 1 hour. And why is that important? Because if I have pain before I get in the car to go see my doctor, and I want to stay ahead of that pain, I want to take that medication about an hour beforehand. If I'm going to go get a CT scan and it really hurts my back when I get my CT scan, I want to take that short-acting pain medicine an hour beforehand. People often ask, why is this different for IV? When I get the IV, it works so much better. Well, it happens much quicker. And the top of that hill for IV is about 10 minutes. So I teach our doctors that instead of giving someone a prescription and saying, hey, call me tomorrow if this isn't working, ideally what you want to do is you prescribe a medicine, you have the patient take it orally, and you have them call you back in an hour, because at that point it's either going to work or it's not going to work. In the same way, in the hospital, what we frequently do is we'll start someone on an IV pain medicine, right? And then we go back and check on them 4 to 6 hours later. So it's quite easy, actually, to just go ahead and make the order, and then we have to write our notes anyways. You know, we all have carpal tunnel now with all the typing we do. So we just sit out, write a progress note while you guys get your pain medicine, and I go in and I check at 10 minutes. How are we doing? We doing good? You know, if they're screaming at me and in pain, we didn't get the right dose. So I think as a caregiver, you can also advocate for your loved one, because you know that if they get a pain medicine that's IV, they should get maximum relief from that pain medicine at about 10 minutes. The same is true for the oral. So 1 hour and 10 minutes. I'm a simple guy, simple rules. So what I want you to just understand is why the IV works so much better is it's more available to you. That's called bioavailability. So your peak is really quick, and patients know this. If they get IV Dilaudid, that's what they feel. They feel that relief right away, in contrast to the oral, or I put here rectal route. And sometimes patients will get a subcutaneous injection or IM, and it's right in between. So 10, 30, 1 hour. So last point. Patients are frequently concerned about, well, you take these medications, how do they get out of my body? And so I think of a glass, in and out. So the vast majority of all these pain medicines are excreted through the kidneys. So as long as you're peeing, you're getting rid of those pain medicines. That's important if you're a caregiver, because if they're not peeing and they're getting confused, we need to know. Okay? Unfortunately, a side effect of a lot of medications is you can get urinary retention. And, you know, guys, you know, in our advanced age, we get those big prostates. It gets complicated. So we've got to make sure we're peeing. One of the first things I always ask if someone is sedated on their pain medicine, are you peeing? In contrast, we do have 2 other medications that are more frequently used in patients who have kidney failure because they're processed and excreted through the liver and the feces. So methadone and fentanyl. They're actually very good drugs, just another tool that we have. But I want you guys to really, the message here is most pain medicines come out through the urine. So anticipating side effects. I have lots of mucinous adenocarcinoma patients in clinic, and many of them are afraid to take pain medicine because it causes constipation. And I think constipation is a big concern, especially with PMP. And so a couple things I just wanted to point out. So with nausea, I would prefer in this particular cancer type to avoid medications like ondansetron or Zofran. It's one of the first ones that everyone gets. And why is that? Because everyone knows it. But the 5-HT3 receptor antagonists have 2 classic side effects: headache and constipation. So I'm not saying that it isn't an effective tool, because it is, but you need to know that it also is constipating. So if you're taking a pain medicine and then also adding Zofran to it, you're increasing your risk of having constipation. So my favorites are Compazine or Reglan for nausea. Both work on the way your brainstem interprets nausea. And the added benefit of Reglan or metoclopramide is it also helps activate your stomach to start churning. This is good as long as you are pooping and have gas, but if you're obstructed, your physicians would know not to use this. Itchiness. So I don't know if anyone's ever been started on Percocet or Norco or morphine and you get this itch. That itch is something that occurs in a minority of patients, but when it occurs, it's not comfortable. So I want you to know that that's a transient effect. It usually lasts 2 to 3 days. And if it's happened to you, you can take an antihistamine to help prevent that. The problem is that the first antihistamine that everyone reaches for is diphenhydramine or Benadryl. How many of you have what I call danced with Benny, where you are just, loopy because of Benadryl? And I'm trying to get all my colleagues to stop with the Benadryl. We have so many more antihistamines. So these second generation Of the second generation antihistamines that are not sedating, the one that's strongest with the quickest onset of action is Zyrtec. My second favorite is Allegra or fexofenadine. Tell your doc you don't want to dance with Benny. And my favorite is we have patients come in for blood transfusion and they get Benadryl, they get a blood transfusion, and then they're asked to drive home. It's really great. So constipation, and I put this at the end here to really emphasize that patients will frequently be told that constipation is a side effect of pain medicines, but unfortunately they're given something called Docusate, which is the little red gel pills, okay? And I forgot my little red gel pill today because usually what I do is I tape it on my forehead because that's about as useful as that medication is in this setting. Because pain meds, opioids, what they do is they slow the motility of the bowels. It has nothing to do with how soft your bowels are or how much fiber you have. It's a stimulant issue. So if you talk to your gastroenterologist, they're going to say, I don't ever want you taking stimulant laxatives. And the stimulant laxatives include Senna and bisacodyl. But the exception to that is if you're on pain medicine. If you're on pain medicine, you really want to be taking Senna or bisacodyl on top of your pain medicine. Maximum doses of Senna, which is here, the picture, are 1 to 8 pills per day. Most people don't know about the 8 pills. Some people need to take 4 and 4, you know? It just kind of depends. Some people, I can't even give them half a tablet of Senna because it's too strong. And so there is a tea that's available called Smooth Move at Jimbo's, which is a Senna tea. We have a lot of pills that we all take. This is an easy one to remember. It's brown. It's a brown pill. Okay? It's the most important one. Remember it. The hands up there are to remind our doctors that if you were going to write a prescription for an opioid with your right hand, guess what you need to write with your left hand? A stimulant laxative. And so I go through this with all of my trainees. Opioid, stimulant laxative. Remind them about nausea, etc. So avoiding constipation. So this is a dynamic issue. Some of us lean towards the looser side of things, and some of us don't. And it all depends on how much you're moving, how much exercise you get, how much hydration you're getting. So every day is different, and I encourage people to become masters of their own domain. In terms of, I have people calling me each day, what should I do? I say, here are your tools, you figure it out. But other medications that you need to be aware of outside of opioids are Zofran, which I talked about. Aloxi, which is a cousin of Zofran, is the 72-hour form of that medication, and people get that prior to chemotherapy. And surprisingly, patients will say they get constipated when they get chemotherapy. Guess what? It's from this drug. So if you have that side effect right around chemotherapy, they give you a medication before you get chemo to avoid nausea. Aloxi is usually one of them. And if you are getting constipated in that setting, it's that you just need to be a little more aggressive about your bowel regimen for those couple of days. It's usually 3 days. Other medications that people take, and we frequently forget, but calcium channel blockers for hypertension, iron. Lots of patients are on iron. With PMP in particular, I would really avoid oral iron. I would talk to your doctors about getting parenteral iron, which is much easier. You get everything taken care of usually in 1 to a couple infusions. And then you avoid the oral supplementation if you have iron deficiency anemia and avoid the constipation. Aluminum-containing agents, antacids. Most of the antacids contain aluminum, which, if used in excess, can cause constipation. And then we talked about the benefits of metoclopramide. And for the doctors in the room, the reason why you get the stomach motility is because of 5-HT4 agonism at the gut. And ideally, you take Reglan 30 minutes before you try to eat, and 4 times a day. I'm from Colorado. I grew up in the mountains in ski country. And so what we used to do before you left for work is you get out in your car and you warm up your car before you got out there. That's kind of like how I think of with Reglan. So right before you're going to go eat, you take your Reglan before to really just at least start the engines, and hopefully things move south instead of north. So everyone in the room, I'm sure, is aware that one of the major risks associated with this is bowel obstruction. And bowel obstruction is where things just aren't moving right, and there's multiple causes of that. There's mechanical and there's and functional. We want to make every effort we can to avoid a bowel obstruction, and that's doing the things that I just described. Frequently, patients will do everything they can, and it still happens. If you get a bowel obstruction, the classic sign is when you eat, it just comes right back up. That's a complete bowel obstruction. Or you have sudden nausea, or sudden vomiting, excuse me. You don't have the preceding nausea. It's happening, and you can't keep anything down. This is a medical emergency, and we need to know about it. There's different approaches to management of bowel obstruction. The surgeons are usually involved. They would need to do an evaluation to see if there's anything that we can do that's reversible. Sometimes if there's a clear target that we can put a stent in, sometimes that's done. And there's a lot of growing interest in effectively using those. But medical management is the cornerstone of malignant bowel obstruction management. And that includes rest, IV fluids, NG tube. This is called the, quote, fluids and suck approach, where you have the NG tube sucking out any fluids that accumulate, which can be up to 6 to 8 liters a day normally. And then you're getting IV fluids. Pain medication, of course, nausea control. There's a drug that we sometimes use called octreotide. I can talk to you about that later if that's something that you have questions about. And then steroids. G-tubes and J-tubes. So gastrostomy tube is a tube that goes out from the outside world into your stomach. A J-tube is one that goes into the part of your intestine. There's benefits of both of these. I would really encourage, we don't like putting tubes in people, and patients don't like having tubes in. But if you are being admitted with multiple bowel obstructions, which requires you to be in the hospital for long periods of time, and you have this really uncomfortable tube in your nose, sometimes I've been able to keep patients out of the hospital by having a tube from below where they're able to control their symptoms from home. So it's a conversation, and it's a conversation that you can have with your doctor if that were to occur, and we don't just do this lightly. Some of the surgeons, if they're really worried about this, will put a tube in after with your surgery, and those usually are patients with more advanced or bulky disease. Weight loss was brought up today, and I will spend some final thoughts on weight loss, which is important to understand. This can be a very, very hot topic and a big struggle between patients and their caregivers. So the weight loss syndrome with cancer is called cachexia. This is a metabolic syndrome. This isn't your typical weight loss where your metabolism is actually increased and your drive to eat is decreased. So anorexia is decreased appetite. This is not to be confused with anorexia nervosa, which is a totally different thing. Anorexia just means you don't have that desire to eat. So this is like at the end of a big Turkey Day celebration, you look at your loved one and you say, here, eat more, and you just can't even look at more food. That's the feeling of anorexia, where you are just, you can't even think about food. Cachexia, though, is something that is a complex metabolic syndrome. It changes due to inflammation associated with the cancer, and oftentimes with metabolic changes and hormone dysregulation. So practical issues. The thing I try to encourage my patients is to avoid the struggle between the patients and the ones you love. So as children, we're taught that if you're sick, mom or dad brings you some soup during your cold and they take care of you. And there's this whole caregiver and recipient role that we all assume. So I show that I'm taking good care of my loved one by feeding them, and I'm being a good patient by eating. And so we're taught this from day one. But at a certain point, if you can't keep food down and someone keeps pushing the food, it can become a struggle. And I don't want that struggle to happen, because then it makes things even worse. So if you ever are feeling like you need to feed someone, which in some cultures, I just got back from Mexico City, is a really big deal. Like that's the only way you show you love someone is you feed them. I think that's important for you just to kind of say, okay, how else can I show my love? And then navigating advice from loved ones. So one of the great ways that we try to control what we can in an uncontrollable situation. And so diet happens to be one of those things that we feel we have control over. And so I just warn patients and loved ones that they're going to get advice on all these great diets out there. I've heard it all. What about the banana peel diet? What about this? What about that? And I think a lot of that I want you to recognize that it comes from a place of love, and they're providing advice, trying to help you in a very bad situation. We're going to get some more advice about the best foods, if you can get them down, what that would look like. But my advice when you're feeling nauseous and you don't have an appetite and you're doing the best that you can, my rule is if it looks good and it stays down, then go for it. I think we're going to hear better advice on that, but I'm a simple guy. So the last part of my talk is just talking about the P word. So the P word is palliative care. And everyone associates palliative care with end of life. And I'm going to show you some evidence that shows that palliative care providers should be involved early on in your care and not wait till the very end. Palliative care is frequently confused with hospice care. So hospice care in this country is available for patients who have a prognosis of less than 6 months. But hospice care is a part of palliative care. And what I do here at the Cancer Center is not hospice care. I'm seeing patients at the time of diagnosis. So the old way of thinking was, you see Dr. Lowy, you see Dr. Fanta, you just keep working with them, and then all of a sudden you hear there's nothing left to do, and then get the boot and you get to go hang out with Eric. And that's how things are operating in large portions of the country. The new way of where things are at is that cancer care and palliative care are integrated. And our role is dynamic and changing. So it might be that you have a new diagnosis of metastatic cancer. You meet your medical oncologist on the same day that you meet your palliative care provider. You say, hey, Eric, I don't need you right now. I say, that's fine, but I'm here. And then when you have nausea or pain out of control, I might play a larger role in your care. It's not that our medical oncologists and surgical oncologists aren't capable of doing all of this. It's just that I have more time to do it, and I have some extra training in it. So this is evidence-based. Most people don't know that. So there's a big study in 2010 by Jennifer Temmel and the group out of Harvard, published in the New England Journal of Medicine, in patients with advanced lung cancer. And the patients were randomized to either receive standard oncology care or standard oncology care plus seeing a palliative care provider. And the patients who saw palliative care had a better quality of life, decreased symptoms, and lived 3 months longer. That's the same amount of time that the FDA approves drugs in this exact situation. So if I were a drug, I would be FDA approved. Now, we thought, oh, that's just Harvard, the Ivory Tower on the East Coast, and Jennifer Temmel is great, and Vicki Jackson is amazing, so they have this wonderful program. It's because of that. So Marie Bakitis, who's a nurse researcher out of Dartmouth and now at University of Alabama, same study, larger group of patients, and showed overall survival also improved across all advanced cancer types. Another nurse working with Marie, Nick Dion Odom, showed that patients received benefit, but guess what? So did their caregivers. Their caregivers had less depression and less stress. Zimmerman, we got a Canadian researcher in on this, 2006 to 2010, same results, improved quality of life. And lastly, Betty Farrell up the street, City of Hope, has just done a study, just recently published last month, showing improved quality of life, decreased spiritual distress, and lower psychological distress. But the key here is no study to date has shown harm. These palliative care providers are not knocking off patients. Okay? So we're all team members. So what I want to do is you'll have access to these slides. There's some resources, and not everyone lives here in San Diego, but you can find a palliative care provider at National Palliative Care Provider Directory, getpalliativecare.org. I happen to know all of the palliative care providers in LA and San Francisco because they all train at our program. So if you need a recommendation, please let me know. We here have a palliative care program and a very active clinical trials program in which I'm conducting clinical trials and symptom intervention studies, anything from weight loss, nausea, pain, advanced care planning. So there's opportunities for you to participate in those studies here. And then Scripps, our colleagues, also have a great palliative care program led by some of my favorite colleagues, Holly Yang and alike. So in summary, maximizing your quality of life, improving your pain control is going to help you live longer. If you're using your pain medicines, use them effectively. So remember, you get the most bang for your buck out of your oral pain medicines at 1 hour. And if it's IV, it's 10 minutes. If you're getting pain medicine, you should also get a laxative, and that laxative should be stimulant, and it's brown color pill named Senna. Good. You're at high risk of developing bowel obstruction, so make sure that we're doing everything not to get constipated because that can make things worse. Remember, there's some options that are available for you, including some tubes that can be placed to help control your symptoms. And then seek out palliative care specialists early. Waiting until it's too late is an old model. Okay? Thank you. It's an honor.